Наступна доповідь Kangtaek Lim, ендоскопія при патології шийного відділу хребта.
Hello, Dr. Lim. It's nice to see you and nice to hear you.
Okay.
Good morning. Hello.
Okay.
Welcome to Ukraine.
Yeah, something wrong.
You can start.
Yes. Yeah. It's a great honor to be invited here today. And then I'm so sorry that I couldn't attend in person. So I will talk about about the endoscopic cervical, the endoscopic operation, the things we can do with the spinal endoscopy in cervical pathology. So we are people performing endoscope spine surgery. So we call the homo endoscopicus. So 2016, I made myself a new endoscopy system with a Maxwell. So we can, after introduction of endoscope spine surgery in spine field, so some of the changes. So I talk about the things we can do with the spinal endoscopy in cervical pathology. So we call the homo endoscopicus. We love to perform endoscope spine surgery. And with the Maximal, we could release a new endo system in 2016. After that, the introduction of the endoscope spine surgery in spine field. So many changes in spine field, and you can do it one school. We can do everything: the posterior approach, lumbar discectomy, the stenosis decompression, and the foraminar, the parasmal approach, some pathology solving, and we can do the lumbar fusion, lumbar and HDF. So the endoscope spine surgery will to ensure the fast return to normal life, and so many changes in the indication of my method of spine surgery, and total case of fusion surgery has been decreased in the endoscopic hospital, and 100% in my hospitals are the endoscopic spine surgery, include all decompression, discectomy, and the lumbar fusion and HDF also. So after introduction, sorry, I call cold. So after introduction of endoscopic spine surgery spine field, the microscopic at the HDF was replaced to endoscopic HDF, and the laminoplasty was no longer necessary, so we can do endoscopic posterior decompression. So with a one skin port, you can do jumping technique, 3-level, with a one skin port, 3-level decompression. And for cervical, you can do 3-level with a one skin port sliding technique. So it's a 3-level lumbar with a one skin port. You can do jumping technique. So I published about this decompression, and then lumbar fusion also, endoscopy that we can do. So because it's a small skin scar. But the main purpose is endoscope spine surgery. There could have not fusion. The first choice could have direct decompression. We need to talk about always how to decompress, direct decompression first. Is the main purpose of endoscope spine surgery. So unipolar endoscope spine surgery very stable. So my elbow is resting on the face in the back, very stable, and we can use the two-end surgery for the cervical, the instrument. Okay. And we use high speed. We can use high speed drill, 64,000 RPM. So we can decompress every pathology in short time, and there's no any muscle manipulation required. So usually the one level lumbar to VLBD will take 20 minutes, and cervical 30 minutes is enough. So I'll talk about the cervical pathology, how to decompress or how to solve the problem in cervical case. So depend on pathology, we can do posterior decompression or anterior approach, the HDF we can do. So first choice could be the posterior decompression or spinal cord decompression, and then the foraminar decompression. It's not available. We can do the anterior approach, the discectomy and HDF we can do. So I'll talk about like this myelopathy as could be another challenge for challenge to overcome as a spine endoscopy surgeon. Most of the patient have a loss of balance and it's very difficult to walk. So, but the society, so as just the big constant debate was anterior approach, posterior approach. So colpectomy, anterior approach, and laminoplasty. But we have another option. It's the anterior posterior approach, the open surgery. But we have another option, could be posterior decompression and the anterior HDF. So the open surgery have the detachment of muscle, and then patient will have a muscle atrophy and hypotoc change eventually. So for endoscopic spine surgery, was no any the hypotoc change. And the first step for the cervical myelopathy could be to check dynamic MRI. It's a flexion extension, it's quite different. This patient, the pathology was the posterior, the apocalyptic ligament flavum. That's why we can remove this only this one for the cervical myelopathy. So with one scope, we can do 8 mm out diameter, ipsilateral decompression, and the contralateral side of approach decompression, foraminal or spinal cord. But surgery, the should be does not detach muscle from the muscle is very important. So the endoscope spine posterior approach, there's no any damage of the posterior ligament complex. Unlike the endoscope open surgery, has the detachment of muscle is like posterior ligament complex is like a main cable of the bridge. So post-operative on open the decompression, there is some instability and the hypotoc change. The first choice could be posterior decompression in unilateral endoscope. So advantage could be with one skin pole, you can do multi-level decompression. But there is no any posterior ligament complex the damage. There was no post-operative hypotoc change. So and then posterior approach we can do, we can avoid the laminoplasty HDF. So the posterior approach we can do foraminal decompression for the root decompression is a motor sensory root and the spinal cord also, everything. Ipsilateral and contralateral side approach. And muscle in cervical is very important in motion stability. So that's why we have to preserve muscle as much as we can. And the scope, there is a very less damage compared to open surgery. So there are big damage. So also the instability is quite frequent. And the approach is the landing point and the system for posterior decompression could be the medial board lateral mass, and then we can do laminectomy and to create a space to handle some using the instrument, and then we can do decompress and foramen, and you can do contralateral side approach decompress also. Indication could be the disc, paramedian disc, pre and post operative, and you can remove the fragment. So you can avoid the HDF, right? Like this. And the foraminal stenosis, pre and post operative, you can do decompress of foramen, but there is no any damage of posterior ligament complex. That's why there is no any hypotoc change post operative. It's one level decompression for cervical, the spinal cord, and the two level, the patient have a localized OPLR, pre and post operative shows quite enough decompression. It's a 3-level the pathology. So with the endoscope sliding technique, we can do 3-level decompression. That's why we don't need to perform the open surgery for the laminoplasty anymore. It's a sliding technique. So first middle and so adjacent level, you can decompress with one skin pole. So ipsilateral decompression, quadrilateral side approach, decompression. It's a 3-level with one skin pole, 3-level spinal cord, 3, 4, 4, 5, and then the 5 or 6. So we don't need to perform open surgery for laminoplasty. So small skin scar. Yes, you can find my chapter and this textbook for about the sliding technique. Okay, and the 4 level you can do. There is no kind of change. And in open surgery, it's had to pressure facet joint more than 50% to prevent the instability post-operatively. But if it's very important to check the CT scan if patient have the orthopedic, we can do the full decompression. It's very important. Sometimes we can do the total facectomy, but there is no any instability because patient have a strong bone. And in motion, the stability in cervical muscle is very important. So that's why we have to preserve as much as we can. And we can preserve the posterior ligament complex. And the C bypass lipofusion injury should be careful. Do not remove the ligand flavum as an envelope. So we have to remove ligand flavum as little by little to prevent the traction injury and direct spinal cord injury. And that if like this the MRI, big huge disc, we have to. It's impossible to remove this disc from the posterior approach. So in that case, we have to performing anterior approach, discectomy, and HDAC. All process can do the under the endoscopic view, discectomy, and like this, cage insertion, post-operative. But there is no any the migration of cage. And advantage of endoscope H-type could be the will the endoscopy provide a good visualization, will guarantee safety, and operation time the around 1 hour is enough. And the post-operative, the anterior soft tissue swelling is very less. And anterior approach, see by 5 small pad. The main cause of the malpath was a calcified disc, and the plan is anterior approach.
Hello,
Can remove
thank you very much.
the posterior, the postopite, and the scope, corresponds post-operative, like this, pre and post-operative, midline corpectomy. So from the 2017, my case are the 250. So clinical outcome, pain, or and cups angle, and about the fusion rate is quite enough. And you can find my chapter in this textbook. And like this huge calcified disc, we can do midline corpectomy, and we cruciate the central corpectomy, and then we can see the cage. Also needle insertion and the serial dilate. Very simple endoscopic instrument. You can do discectomy, and then as a cruciate the central corpectomy can do, and then you can see the cage. It's a video. It's inside you can see calcified fragment, and then you can set it up pulsation spinal cord like this, pre and post operative. So very important to preserve anterior visceral organ, and we can push the anterior visceral organ to using the finger to the opposite side. We can insert the needle and the serial dilate, and we can use the endoscope system. So compared to open surgery, with a small skin scar, you can do discectomy, and then it's a before operation or after remove PLL, you can see dural pulsation, and then you can insert cage under the endoscope view. This patient have the 2 pathologies on flexion extension, so we have to remove this 2 pathology. First, we can try posterior decompression, and then anterior approach, discectomy, and HDF. Okay. First, endoscope posterior decompression, and then you can do HDF. All the male patients have also 2 pathology, posterior decompression and anterior approach step. And AP diameter preoperative was less than 5 millimeter, but post-operative 15 millimeter we can do. Like this. Posterior decompression, anterior step. After removal of the disc PLL, you can see the dural pulsations. Yes. First, we can insert the endoscope cage hole, and you can set cage, and then we can insert cage into disc space. Final case, 5-6, very narrow space, posterior decompression first, and anterior approach discectomy and cage insertions. So conclusion, so with the endoscope, we can do the pathology, the posterior approach depend on the pathology location. So that's why we need to check up dynamic MRI is very important to know the location pathology, posterior decompression or the anterior age depth. So education program endoscope spine is very important by the hospital. If anyone, patient, the doctor want to visit my hospital, let me know. It's every month, my cases will reach to the 70 case every month, endoscope spine surgery. They email me. And then, so the Mr. Peter Proctor will arrange your program in my hospital. And this is September 30, I will organize an endoscopic cervical international spine conference, the first in Korea. So please join us. And next generation endoscopy could be the electron endoscope. So soon we will release, you can release the electron endoscope. It's very cheap, and in terms of durability, very strong. You can use this electron endoscope soon. So it's the first, it will be the first step of tele-remote operation. It's right side is electron endoscope, it's left side is the optic lens. But difference, color difference, but clarity is more better in the electron endoscope. Like this. So it will be the first step of a tele-remote surgery. In my operation room, so I have it's a remote the operation, it's a lab. So with this electron endoscope you can use, and then you can use the joystick in the hospital. Patient is in another country, so we can use we can try the remote surgery in the near future. Okay. So the teams have some education program in the world with a Kangtaek workshop. So please join us. Thank you.
Thank you very much, Dr. Lim. Everybody knows that you are a talented endoscopic spine surgeon. Thank you very much. It was a big pleasure for us listening to your presentation. Thank you.
Thank you.
Hope next time you will have a chance listen to your presentation offline.
Yes.